Thank you very much for that very kind introduction. And I want to add my sincere thanks as well to Dr. Pai for the opportunity to be here today, for the wonderful hospitality that you have shown each and every one of us, and your presence here today speaks volumes. So thank you so very much, for that. I am a GYN oncologist. I practice in the state of Kansas, in Kansas City. My state is a little bit to the west and a little bit to the south of Iowa that was just shown to you by Dr. Gelhaus. And I want to say thank you to Dr. Gelhaus because you have been a mentor as ACOG president to many of those of us who have followed in your footsteps. So thank you very much for that. I'm going to talk today about a clinical topic of atypical endometrial hyperplasia. I have no disclosures, and I hope that after this 20-minute brief talk that you will understand the definition of atypical endometrial hyperplasia and endometrial intraepithelial neoplasia. We will discuss its diagnosis. We will review current clinical consensus guidelines on treatment options, and then a brief discussion on prevention. And this material all comes from a recently published clinical consensus document by ACOG on the management of atypical endometrial hyperplasia, published in September of 2023. First and foremost, endometrial intraepithelial neoplasia and atypical endometrial hyperplasia are the same entity. Their definition pathologically depends on which classification system you use to give one subject title, endometrial intraepithelial neoplasia versus atypical endometrial hyperplasia. But this lesion is important because it is often the precursor lesion to endometrial cancer. So first big take-home message is endometrial intraepithelial neoplasia and atypical endometrial hyperplasia are the same entity. It just depends on which pathologic definition is being used. This is ACOG's look at what the pathologic definition is, comparing on your right a normal endometrium versus on your left an atypical endometrium. The atypical endometrium shows crowded glandular architecture as compared to the normal endometrium. You also see altered epithelial cytology, and you will see entrapped benign glands within the complex crowded glandular architecture. So this is the pathologic definition that we are looking for. And for the rest of my talk, I'm just going to call this finding atypical endometrial hyperplasia. An important also pathologic finding that we see with this entity is that it is not a uniform across the endometrial lining process, that you could have a lesion in the fundus of the endometrium as well as a lesion in the lower uterine segment or upper endocervix. And this will become important as we talk about surgical management of this process. The cause of atypical endometrial hyperplasia is really estrogenic overstimulation of the endometrium, which is often caused by unopposed progestins. And this results in first an hyperplasia, which can then ultimately change to atypical hyperplasia. Atypical endometrial hyperplasia expresses both estrogenic as well as progesterone receptors, and this becomes important when we talk about medical management of this process. So the distinction between hyperplasia and atypical endometrial hyperplasia is important, as each condition has differing cancer risk and interventions to avoid under or over treatment. Atypical endometrial hyperplasia is associated with pathologic microsatellite instability RAS mutations, as well as loss of immunoreactivity to PTEN, PAX2, and the mismatch repair proteins, which we can see related to Lynch syndrome. So, warning and importance regarding the diagnosis of AEH is that upwards of 30 to 50% of patients who have this pathologic entity will have a concurrent endometrial cancer at the time of diagnosis. 30 to 50%. And this is based on studies where preoperative biopsy of atypical endometrial hyperplasia was compared to final pathologic diagnosis at the time of hysterectomy, showing the high association with cancer and this diagnosis. So this is important because obviously our goal is to prevent endometrial cancer from occurring or to make the early diagnosis in the case that cancer is present. Part of ACOG's consensus recommendation regarding the diagnosis of atypical endometrial hyperplasia is the importance of the diagnostic sampling. So it is our recommendations that in order to have the best preoperative diagnosis to exclude a cancer is to perform a hysteroscopic evaluation and targeted biopsy based on the visualization that is seen at that time. So do not depend only on an office-based Pipel-type sampling to attain this diagnosis. Our consensus recommendation is hysteroscopy with directed biopsy. So now we'll switch gears from diagnosis to talking about the management of this diagnosis, surgical and medical, starting with surgical. The consensus recommendation is if you have a diagnosis of atypical endometrial hyperplasia, that the primary treatment should be a hysterectomy. And it is very important, as we reviewed earlier, the pathologic findings of atypical endometrial hyperplasia, that a supracervical hysterectomy is not appropriate for this diagnosis because it may miss the lower uterine segment upper endocervical lesion that could be present at that time. Hysterectomy is the primary treatment and the #1 recommendation by our consensus station because our primary goal is, 1, to rule out cancer, and #2 is to prevent a cancer from developing. And by performing the hysterectomy, we have completed both the primary as well as the secondary diagnosis. Other surgical considerations when you start to think about hysterectomy for these patients are the decisions of salpingectomy and or concurrent oophorectomy. From ACOG's work on looking at salpingectomy at the time of hysterectomy, we do recommend salpingectomy to be performed at the time of hysterectomy for this diagnosis, as well as salpingectomy when you are considering hysterectomy for any patient who has completed their fertility. The decision to perform oophorectomy is much more of a shared decision process, particularly in the premenopausal or perimenopausal patient. And that discussion is also a very important part of maintaining the woman's health for the long term. We do also recommend at the time of surgery consideration of intraoperative assessment of pathology. But if you do not have immediate pathologic evaluation available, as well as the availability of GYN oncology consultation, then consideration of intraoperative assessment of pathology may not be appropriate and best to just wait for final surgical pathology evaluation. Another part of our consensus recommendation for atypical endometrial hyperplasia is that there is no role for endometrial ablation, whether it be thermal, radiofrequency, or electrocautery. And this is because of the high persistence rates that may occur with any type of endometrial ablation, as well as the potential difficulty of reevaluating the endometrial cavity should recurrent bleeding or other findings necessitating evaluation of the endometrium occur. So now we will go to medical management. Our consensus recommendations are that progestational agents as treatment are the primary recommendation medically if hysterectomy is not an option. Studies have found a very high response rate to progestational therapy. Depending on the individual studies, regression rates can occur 60 to 90% of the time. These are the current progestational agents that are recommended, as well as the regimens for the recommendations. We do not have a consensus recommendation of one of these progestational agents over the other. Looking at the data on superiority of oral versus intrauterine progestational agents, we do not have a very robust clinical background to say that oral versus intrauterine administration is superior. However, there have been studies that do show that improved regression rates with combined intrauterine and oral progestins may be more significant than the use of intrauterine progestation IUD alone. So we do have some evidence by this reference by Fang et al. Showing combined intrauterine and oral therapy may have the highest regression rate. Compared with systemic therapy only, adverse events using intrauterine progestational source are uncommon. And so patient adherence with intrauterine progestational agents have a much higher success rate with less systemic side effects such as weight gain and other medical complications such as with MEGACE, there can be increase in deep venous thrombosis related to oral therapy use. So from a consensus guideline standpoint, there is insufficient evidence at this time to recommend one formal oral progestational agent over another. Treatment follow-up. For those who are initially treated with progestational agents, reevaluation at 3 to 6 months after the diagnosis of AEH is our recommendation. And this is a table summary looking at response rates compared to recommended follow-up. If in the first 3 to 6 month reevaluation, a biopsy shows a complete response, then a repeat biopsy 9 to 12 months later, and to continue to reevaluate at approximately 6 to 12 month intervals, up to 24 months, can be followed. Hyperplasia with no atypia result at the initial post-treatment follow-up. Again, continuing to rebiopsy at 3 to 6 month intervals is recommended. If there is persistent disease but no cancer, again, continued follow-up at 3 to 6 month biopsies can be considered. But if a 3-month biopsy shows a cancer, then management as appropriate for that change should be attained. So following initial progestational treatment, if you get regression to a normal endometrial biopsy, you can consider long-term maintenance therapy with progestational agents, particularly in patients who have risk factors for endometrial cancer. And those risk factors can be summarized here. Modifiable risk factors are those patients that presented to you with estrogen stimulation with no progestational agents, so removing the unopposed estrogen therapy. Another modifiable is obesity. Today, with our GLP-1 receptor agonists, we can see that there is definite improvement in obesity, which can certainly affect the long-term outcome of response to therapy. In the non-modifiable risk factors, diabetes is kind of moving over into a potentially modifiable process as we look at the new medications that are being evaluated. So, looking at lifestyle changes are important as we try to prevent not only atypical endometrial hyperplasia, but to prevent cancer from occurring. And attaining weight loss, glycemic control can certainly improve the overall health of our patients that had this diagnosis initially, but more important for our patients who have risk factors to try to prevent this diagnosis as well as the diagnosis of endometrial cancer to occur. So, part of our charge, I do believe, is talking to our patients about lifestyle modifications, as nearly 70% of endometrial cancer survivors have obesity. And most of these patients are unaware that their cancer or endometrial hyperplasia, atypical hyperplasia, are cancer linked. And even a weight loss of 7 to 10% is found to have significant change in outcomes for these patients. One comment on post-treatment pregnancy rates are approximately 30 to 40% in patients who had desired to attain fertility even in the presence of atypical endometrial hyperplasia. But for the majority of these patients, assisted reproductive technology was required to attain the pregnancy. So in conclusion, 1, we do recommend hysteroscopic evaluation to rule out cancer with a diagnosis of atypical endometrial hyperplasia. Number 2, hysterectomy is the definitive treatment of choice, but not a supracervical hysterectomy, nor an ablative therapy. Non-surgical management for those patients who are not candidates or who desire to attain or retain fertility is very possible with progestational agents, but the superiority of oral over intrauterine progestational agents are lacking with minimal scientific data, as previously discussed. Follow-up, as we discussed, at 3 to 6 months after the initial treatment with progestational agents, and looking for our future to continue to look at prevention of this diagnosis as well as endometrial cancer by assisting our patients with lifestyle modifications. So thank you all very much. I want to give a thanks to our ACOG Clinical Consensus GYN Committee. It is people like you who sit at ACOG who make these recommendations, and also thanks to Dr. Chris Zahn, who oversees our GYN and our Clinical Consensus Committee. So thank you very much.
Thank you. I think that was an excellent rendition.